This is the recording for the final review for care of the patient with chronic conditions. So we'll start off with elimination. Urinary catheters. You got to remember it's a sterile procedure. Before we remove them, we always want to deflate the balloon. If at any point the catheter is no longer sterile, like it hits the leg or anything, we want to replace it. If the catheter, when you're doing a cath on a female, slips into the vagina, you want to get a new catheter. Another thing you want to do is leave it there, so when you put the new catheter, you don't go into the same space. And again, it's a sterile procedure, and if at any time your catheter becomes contaminated, you need to get a new catheter. We need to know the appropriate reasons for urinary catheterization. So we want to catheterize, of course we need an order, but reasons that we're going to put in a catheter as a nurse are urinary retention, a critical illness where you're going to need close hemodynamic monitoring, like you need to know a very specific I's and O's, you will see a catheter in that situation, or if somebody's going into surgery. We never put a catheter in somebody just because of incontinence. It's an unnecessary risk for infection. So appropriate reasons are urinary retention, critical illness, surgery. Inappropriate reason is urinary incontinence. So if we have somebody who has a catheter and we have the situation where they have a large fluid intake, but they have a small urinary output, the first thing I'm going to do as a nurse is assess. I'm going to look at that catheter. I'm going to look to make sure it's not bent, kinked, clamped, or it's not underneath the patient, something that's obstructing the urinary flow. That's the first thing I'm going to do if I have somebody with a large fluid intake and a small urine output. I'm going to assess that catheter and make sure that there's no occlusions and that it's functional. Condom catheter, we want a space of 2.5 to 5 centimeters, that's 1 to 2 inches, between the tip of the penis and the end of the catheter. The space helps prevent irritation of the tip of the penis and allows for full drainage of urine. Adhesive tape will not expand with changes in the size of the penis and could possibly impair blood flow, and it's painful to remove. Therefore, it should not be used to keep a condom catheter in place. When you're placing a condom catheter, there'll be no manipulation of the foreskin required, and the catheter is rolled smoothly over the length of the penis and not stretched along its length. Risk factors for UTI, women versus men. Women have a higher incidence of UTI compared with men. They have a shorter urethra and a shorter distance from the urethra to the anus. A shorter distance will increase the risk of infection because the bacteria has a smaller distance to travel. And again, the shorter distance between the urethra and the anus increases the possible risk of fecal matter getting into the urethra. Men also produce an antibacterial substance in their prostatic secretions, which helps reduce the risk of infection. Prevention of UTI. Always use sterile technique when putting or placing a Foley catheter. You want to give appropriate hygiene and care to the genital region. We want to assess our system. We want to keep it closed. We want to avoid stool contact with the catheter and at the urethral meatus. So when we clean the patient, if let's say they're incontinent of stool or we're doing a bed bath, we want to clean the patient from clean to dirty. So we start at the urinary meatus and we end at the anus. And then bladder scanners. They've eliminated the need for in and out catheterization when we suspect urinary retention. Preventing UTIs, we teach our patients to wipe from front to back. We avoid bubble baths, keep blood sugars within normal range, and empty the bladder frequently and completely. UTI signs and symptoms. The patient can have an elevated white blood count. The urine is going to have a pungent odor. You can see sediment in the urine. Confusion or altered mental status can be a sign of a UTI, especially in the elderly. Change in urinary pattern could indicate a UTI. Somebody might have urinary frequency and they may not be able to completely empty their bladder. Cloudy or dark urine is also a sign of a UTI. Long-term indwelling catheter. The client should take a shower rather than a tub bath because sitting in the bath allows for bacteria to have easy access to the urinary tract. The drainage bag should be emptied regularly, not once a day, but at least 3 times a day. The drainage bag should be hung below the bladder. Adequate amounts of fluid should be consumed to prevent sediment and infections. Pregnancy changes in elimination pattern. Large volumes of urine because she has larger blood volume during gestation, and this can cause urinary frequency. As the fetus grows, it puts pressure on the bladder, causing frequent urination. The use of prenatal vitamins with iron can contribute to constipation in the pregnant female. A TURP, transurethral resection of the prostate. It's most widely used procedure for prostate gland removal. It's normal to see blood right after surgery. Empty the drainage bag as needed. You have to subtract the amount of irrigant infused from the total output to obtain the urine output record. So again, with the TURP, it's a continuous bladder irrigation. So whatever solution that the provider prescribes is flushing into that bladder. So you have to take into account anything that was flushed into the bladder, and you'll subtract that from all the output in the drainage bag to get the amount of urine. Post-TURP, the client should be encouraged to incorporate fruit juice in his diet to keep bowel movements regular and soft, to avoid straining. We don't want the person to strain with bowel movements because it can cause increased pressure in the prostate area. The client may not drive for 2 weeks after surgery. The client is taught to avoid heavy lifting for 4 to 8 weeks after discharge. And we instruct them to call the doctor if they see any heavy bleeding. They might have some minor bleeding when defecating, coughing, or exercising, but we do want them to notify the doctor for heavy bleeding. Iodine allergy versus shellfish allergy. People with a shellfish allergy will react to certain proteins found in shellfish. Shellfish include marine creatures with shells, including crabs, shrimps, lobster, oysters, scallops, and as well as squid and octopus. We're going to use chlorhexidine antiseptic instead of providone iodine, just because the iodine and the shellfish have a cross allergy or could possibly have a cross allergy. Latex allergy, an immune response that leads to tissue with tissue integrity. Allergic reactions are examples of an immune response. So with this, we want to know all our foods that can have like a latex allergy or a cross allergy. Foods that could possibly have a cross allergy with latex include bananas, avocados, kiwis, plums, peaches, cherries, apricots, figs, papayas, tomatoes, potatoes, and chestnuts. So if somebody has an allergy to one of those foods, we don't want to use latex catheters with this person. We don't want to use latex gloves. We're going to remove all products containing latex. So we mentioned the gloves, tourniquets, tape, and then again, if we needed to, or we had an order to insert a Foley catheter, we're not going to use a latex catheter on a person who has any allergies to bananas, avocados, kiwis, plums, peaches, cherries, apricots, figs, papayas, tomatoes, potatoes, or chestnuts. Activities to promote a healthy bladder: adequate hydration, emptying the bladder with the first urge, maintaining a normal body mass index, refraining from smoking, minimizing caffeinated beverages, and maintaining regular patterns of elimination. Clean catch urine sample, male. You want to instruct them to retract the foreskin to expose the urethra. We don't want the foreskin to go over the meatus, the urinary meatus, because it's going to contaminate the sample. They're going to use a circular motion to clean the meatus, and they're going to use each towelette once and then discard. Void a small amount before collecting the sample, and the sample is collected midstream. Collecting a CBG, use the size of the finger. We want to heat, like if we're having a difficult time collecting a sample, when we're trying to get a CBG or a capillary blood glucose, we can heat, like we could put a washcloth in warm water and use that on their finger. It increases blood flow, causes vasodilation, and makes the sample easier to collect. We can also dangle the hand lower than the heart. This is going to provoke blood flow to the fingers. After we collect the sample, we're going to follow the patient's sliding scale. Collecting a wound culture. Collection from the crusty area around the outside of the wound or from the dressing. It might be colonized with microorganisms that haven't affected the wound, and it's going to give us an inaccurate result. So again, I don't want to remove the dressing and get sample from the dressing itself or anything that's already started to crust around the wound, because it's going to give me a false positive most likely. If we use an antiseptic solution before we collect the specimen, we're going to remove any bacteria that would have been present in the sample. So wounds should be cleaned with normal saline or sterile water to remove any skin flora prior to collecting the specimen for the wound culture. And we want to rotate the swab in the center of the wound base. So we do clean with normal saline or sterile water. We don't use like betadine or any type of antiseptic solution because it's going to give me an inaccurate result and remove any bacteria that could have been present in the sample. Decreasing constipation when taking iron. We want to increase physical activity, fluid intake, and dietary fiber. Other causes of constipation are poor diet, poor fluid intake, and immobility. Collection of a stool specimen for fecal occult blood testing. Obtain specimens from 3 different stools. Fat intake will not affect the results of the testing. The specimen cards do not need to be refrigerated. Increasing water and fiber intake for a few days prior to testing facilitates collection of multiple stools. Vitamin C, red meat, poultry, seafood, some raw vegetables can cause false positive fecal blood results. So vitamin C, red meat, poultry, seafood, and some raw vegetables can give you a false positive. Types of incontinence: stress, leakage of small amounts of urine during physical movement, coughing, sneezing, exercising; urge, leakage of large amounts of urine at unexpected times, including during sleep; overactive bladder, urinary frequency and urgency, with or without urge incontinence; functional, untimely urination because of physical disability, external obstacles, or cognitive problems that prevent a person from reaching the toilet. So the example that I've given with this one is, let's say you have a patient who cannot physically take themselves to the toilet, and the call light is not answered in time, and they experience an episode of incontinence. So if we don't get to them in time, they're going to have functional incontinence because we don't physically take them to the toilet. Overflow, unexpected leakage of small amounts of urine because of the bladder is full. Mixed, usually occurrence of stress and urge incontinence together. Transient, leakage that occurs temporarily because of a situation that will pass. Infection, taking meds, colds with coffee. As the body ages, there are anatomic changes that increase the risk for urinary incontinence. However, this is not a normal part of aging. It's appropriate for the nurse to gather more information regarding the client's incontinence, but it's beyond our scope of practice to recommend something like surgery. Like if we find out some or anything like that, that's beyond our scope. Telling the client the nurse understands does not help determine the cause of the client's incontinence. Autonomic dysreflexia is a syndrome affecting patients with spinal cord injuries above the thoracic level. A stimulus from the autonomic nervous system causes hypertension, bradycardia, severe headaches, pallor below the level of the injury, and flushing above the level of the injury, convulsions, stroke, and death. The most common causes are constipation and full bladders. So we have a patient with a thoracic injury, and they are exhibiting these symptoms. We could go ahead and assess, is there any reason that I believe that the bladder is full? Do they have an indwelling Foley catheter? If they do, I'm going to go in there. I'm going to assess, make sure that it's not clamped. If I can determine that a full bladder isn't the source of the autonomic dysreflexia, the next thing I'm going to do is I'm going to assess the bowel record. When is the last time that this person had a bowel movement? It's constipation the cause of the autonomic dysreflexia. So if it's a full bladder and I can see it's clamped, let's say it was an indwelling Foley catheter that's clamped, I'm going to remove the clamp. If it's constipation, does the patient have anything for constipation? Like any suppositories or laxatives or something that's going to alleviate that constipation. Let's say I determine that they don't have an indwelling Foley catheter, but I do a bladder scan and I determine that their bladder's full and they're experiencing urinary retention. At that point, I might ask the doctor for an order for a straight cath. So gas exchange. Oxygen is flammable. So oxygen safety, we avoid smoking when using, avoid materials that generate static electricity, and avoid flammable materials such as acetone, oil, or alcohol. And fire extinguishers should be readily available. Pulse oximeter is a diagnostic test that the nurse will implement to know if the patient is receiving enough oxygen. Chest X-ray produces an image of the heart, lungs, airways, blood vessels, and bones of the spine and chest. Just to add to the pulse oximeter, we see if the patient's getting enough oxygen, and it measures the oxygen level saturation of the blood. Arterial blood gases, it's a test to measure the acidity, pH, of levels of oxygen and carbon dioxide in the blood from an artery. Respiratory rate, a person's respiratory rate is the number of breaths they take per minute. So pneumothorax, clinical manifestations. Thorax unsymmetrical with unequal thoracic expansion. So it's unequal chest rise. We're going to see an increase in heart rate, blood pressure, and respiratory rate. We're going to see a decrease in SAT, and we'll have diminished lung sounds on the affected side. Preventing post-surgical respiratory complications, deep breathe and cough at least every 2 hours, and use an incentive spirometer. This is inhaling. So just something to realize about our incentive spirometer. It's inhaling. And we're inhaling to try to fully expand those lungs. We want to ambulate our patient, get them up, get them walking, increase fluids. And I want to assess my patient. If my patient is becoming confused, I'm going to suspect hypoxia. Collecting a sputum specimen. Sputum is not spit. We want to keep the cup sterile. If the client spits in the cup, get a new cup. Oh, and an incentive spirometer can also help you get a good sputum sample. We want something deep, like the loogies. And I wish I would have thought of something better than loogies for our name of sputum. But anyhow, the sputum, the deep stuff, not just the spit that's like in the mouth. And we can have them deep breathe and cough, use that incentive spirometer to get that good sample. Avoiding influenza and pneumonia. Yes, we want to wash our hands and we want to use hand sanitizer, but vaccine is going to be the best way to avoid influenza and pneumonia. So we do want to wash our hands, use hand sanitizer, but vaccine is going to be the best way to avoid. So people with chronic respiratory conditions require a high-calorie, high-protein diet. They're using a lot of energy to breathe, so they require those extra calories, that extra protein. So high-calorie, high-protein diet for people with chronic respiratory conditions. NG suctioning. So again, this is another one of our sterile procedures. If at any point in time I suspect or if the catheter becomes contaminated, get a new catheter. It touches the tip of their nose or something if you're doing NG suctioning and you need to get a new catheter. You think it might have brushed against their gown, get a new catheter. Chest tubes. We want to avoid any forceful manipulation of the tube. This includes milking or stripping of the tubing. Like what that means is like if you're holding a piece of the tubing and you're either using like your fingers or something to try to push the fluid or assist in the drainage getting into the container, that's something we do not do. We don't milk or strip the tubing. When the patient is coughing, they're going to splint the affected side to promote comfort. The device is kept upright at all times. The device is kept lower than the lungs, the collection container. It's kept upright and it's lower than the lungs. Continuous bubbling in the water seal confirms a persistent air leak, either in the patient's thoracic cavity or possible tube connections. Intermittent bubbling with gentle float auscultation confirms the presence of intermittent leak. No bubbling with minimal ball float auscultation at the bottom of the water seal indicates no air leak is present. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak. So ideal out of those 4 things, what I want to see is no bubbling with minimal ball float auscultation at the bottom of the water seal, because that's going to indicate no air leaks present. Tracheostomy care. I want to ensure that I'm doing something to protect the skin from breakdown. I'm going to make sure that there's that gauze to try and protect the skin from getting any pressure from the trach or any of the plastic pushing down on the patient's skin. I want to assess frequently for breakdown. I want to take into consideration any time that I might need a second person for the procedure. If I have somebody who's really confused, or a very young child that's not going to comply, or anything that's, if it's going to be really difficult, I'm going to ask a second nurse to go in with me, just in case I need any assistance. We use normal saline as the soaking solution, and remember, trach care is a sterile procedure. Know how to calculate your intake and your output. What I mean by like intake, if you are doing like a meal, you're doing the intake for somebody's meal. If I have a 12-ounce can and the person drinks half of it, how many ounces is that? And then what about stuff that when it's at room temperature, it's liquid? Does that count as our intake? So just be sure that you're going to know how to calculate the intake for a patient. Like what I mean by something like that is liquid at room temperature, like a popsicle. Does that go in on our intake for fluid? What about ice cream? So yes, the popsicle and the ice cream, I guess I should give that to you, are going to be as part of our fluid intake. Negative pressure wound therapy. It's the application of subatmospheric pressure through suction. It facilitates wound healing, collects wound fluid, primarily affects the wound surface. Average length of treatment is 4 to 6 weeks. So your patient, he gets a wound vac and he's like, oh, this is going to get my wound healed up week or two. You might have to tell him, no, this is a pretty significant length of treatment. It's kind of a long time. It's average treatment is 4 to 6 weeks. So if they think it's going to be something that's going to almost immediately heal their wound, that might be something where we explain to them that it might take a little bit longer. Dressing changes are completed every 48 hours. If they're infected, it's every 12 hours. We do this for wounds that are not healing. I've seen this on like dehiscence, like if a surgical wound dehisces, I've seen that on there. I've also seen it on other wounds too, but we use this for wounds that are not healing. So as a nurse, when I'm assessing to see if this treatment is effective, I'm looking for wound contraction. And what I mean by wound contraction is that wound getting smaller. Are the edges coming together? So we take measurements and we just assess, and we are looking to see that that wound is contracting and getting smaller. If the patient is going to be always turning this off, this might not be a good treatment for them, because if it's off for longer than 2 hours, we need to tear it down and put a new dressing on, because that black foam is just sitting there and it's stagnant and it can become infected if it's not infected. So if somebody is not going to be compliant with this treatment, it might not be the best treatment for them. So place the steps for a sterile surgical dressing in order. So this was one of our skills that we checked off on. So am I going to go in there and put on my sterile gloves, then take off my dirty dressing? No, because then now my sterile gloves are contaminated. So I'm going to perform hand hygiene. I'm going to put on clean gloves. I'm going to remove the dressing, perform hand hygiene, open any supplies that I need to open, put on my sterile gloves, and then I can manipulate the supplies that are open, because it'll be sterile to sterile. Like any of my stuff that is like sterile to clean with, I will have my sterile gloves. So just make sure that you maintain sterility in changing your dressing. Spiral elastic bandages. Go back to your PowerPoint on this and look at your ankle support, your knee support, wrist support. And just remember, always we are wrapping our extremities from distal to proximal. So distal, away from the body, to proximal, to close to the body. So if I needed to wrap a forearm, I'm going to start at the wrist and end at the elbow. Home care, when it comes to wound care, we want to select the dressing on what's going to work for the patient. If they're going to have to be changing them themselves, we are going to want to select a dressing that the patient is able to change themselves. If I'm going into a house and I'm doing like a sterile dressing change, I might be aware, like if there's pets or something on an area, like if I need to clean it before I put my dressing supplies on there, I might want to take into consideration cleaning it before I put my clean dressing supplies on a possibly contaminated surface. And I want to make sure I do all the documentation required for reimbursement. Transparent dressings or occlusive dressings. You might see these called Tegaderms. Tegaderm is the brand name, but it's a transparent or an occlusive dressing. These are our clear dressings. These can be used on skin tears, stage 1 pressure ulcers. We kind of like walk the dressing over the area, like kind of smoothing it out to avoid wrinkles. This type of dressing maintains a moist environment that uses the body's own enzymes to heal. Avoiding pressure ulcers. Individualize the client's bathing schedule. Daily baths are not essential. Rationale is daily cleansing can destroy the skin's natural barrier, making it more susceptible to external irritants. Avoid hot water. The rationale is tepid water prevents injury of the skin. Use mild cleansing agents to minimize dryness. Cleanse skin immediately. If fecal, urine, or wound drainage seeps onto the skin. Provide humidity to prevent drying of the skin. Use cream or a thin layer of cornstarch to protect the skin. Ensure adequate fluid intake. Rationale is dehydration is a risk factor for pressure ulcer formation. Good nutrition, adequate protein intake. The nurse should consult a dietitian to identify ways to improve the client's intake and support wound healing. Maintain the head of the bed at the lowest degree of elevation possible. Avoid creating pressure areas like bedpans, donuts, Foley tubing, IV tubing, like sheets that are bunched up or trash in the bed. Because of the way we were this semester, I think I might have shared with some of you, some groups, but not all of the groups. But I remember going into a room. I was going to change a dressing on the back of this gentleman's thigh, and I looked at it, and you could see like the S shape, and it was his Foley. He had like a stage 2 pressure ulcer because unfortunately he was left on top of his Foley. So we need to avoid these preventable pressure ulcers. So make sure the tubing's not under them, whether it's Foley tubing or IV tubing. Don't leave people on a bedpan for a prolonged period of time. If you're going to go in and give medications, make sure all your trash comes back with you. Don't make sure there's no like syringes or caps of syringes or anything left in the bed sheets. And then sometimes people don't think about, like the same thing with the bedpan. The bedpan, if a person's on the bedpan, it's going to create areas of pressure where the bedpan is raised. When people put donuts on their wheelchairs, it's also creating, it's not as hard as a bedpan, but it is creating that area of pressure where the donut is higher. So we don't want people to use donuts on their wheelchairs. Complete a Braden score. Medicare will not pay for treatment if an initial assessment wasn't completed. So with this, whether you're getting a patient into the hospital or a long-term care facility, you need to ensure that that Braden is completed upon admission. So if a hospital doesn't complete that and they got a patient from the nursing home and they had a really bad pressure ulcer, but it wasn't documented upon admission, there's no way of saying they didn't obtain that pressure ulcer at the hospital. Barrier creams such as zinc oxide can protect the skin. Barrier creams and ointments are used for patients prone to skin breakdown from pressure, shear, incontinence. They are intended for prevention, or like in stage 1 pressure ulcers. So know your nursing diagnosis for impaired tissue integrity. So impaired tissue integrity, something's already going on. They already have a pressure ulcer. And tissue integrity is impaired. It's already impaired. So risk for impaired tissue integrity, we have those risk factors like immobility, malnutrition, incontinence. They are risk for skin integrity, are impaired skin integrity. Sutures, client teaching. We want to instruct the client to eat food high in protein, consume carbohydrates, vitamins, and minerals to promote wound healing. They will splint the wound when coughing or from moving in and out of the chair, like if they have like an abdominal sutures. Provide a list of signs and symptoms of infection or delayed wound healing, and make sure they're aware of things that they need to notify the physician about. So again, like signs and symptoms of infection. Is the wound warm? Is it red? Is it raised? Is it painful? If the patient sees any signs of delayed healing, like dehiscence, and you're not going to teach your patient like dehiscence, or you may, but you just want to explain to them what that is, that the wound is coming apart, it's separating. So all of those things are things that we want to teach our client to report to the physician. We want to encourage the use of daily showers. Water may run over the wound. I'm not going to use like excessive soap or scrub that wound too much because I don't want to macerate it. And again, with the same thing with the maceration, I don't want it to become overly wet. So just going to let water run over it, maybe a little bit of soap, but I'm not going to aggressively clean that wound with soap. And then also to avoid maceration, I'm going to avoid the use of lotion, creams on the incision. And it's just because we don't want it overly wet because it might come apart. We want to instruct the patient on the dressing change procedure and of any lifting instructions dependent on where the wound is. They might not be able to lift something over 10 pounds. And when they come back into the office to have the sutures removed, as a nurse, I'm going to remove the sutures every other suture, and I'm going to assess for any gaping areas. If there are any gaping areas, or I suspect that it's not healed correctly, I'm going to inform the physician. They may want to leave it on a little bit longer, but I don't want to continue removing the sutures if I see any gaping areas. Hydrotherapy is the external use of water in the medical treatment of certain diseases. Most burn units in the hospital have hydrotherapy rooms. Hydrotherapy softens and removes dead tissue, enabling new healthy tissue to form and promote healing. Hydrotherapy for burns can start within a few days of the trauma once the patients have recovered from the initial shock and the condition has stabilized. Cleaning wounds. Normal saline is the cleanser of choice. When I'm cleaning the wounds, I'm assessing. I'm looking for signs of infection. Signs of infection include purulent drainage, odor, pain, redness, tenderness, and fever. So serous drainage is thin in consistency and it's clear in color. Serosanguinous is thin and watery in consistency, but pink to light red in color. Sanguinous is a thin consistency, but bright red in color. Purulent is either thin or thick in consistency. It can be tan to yellow in color. And our purulent drainage, again, that's our drainage that I'm suspecting infection. A culture is the name of the test that's done when infection is suspected. A wound culture is a test to find germs such as bacteria or fungus that can cause infection in a wound. So things to know that suppress wound healing. We have corticosteroids, uncontrolled high blood sugars, smoking, low albumin, dehydration, and hypoxia. So again, things that suppress wound healing include corticosteroids, uncontrolled high blood sugars, smoking, low albumin, dehydration, and hypoxia. So again, our signs of infection, the skin is warm and red, inflammation, elevated body temperature, pain, purulent wound drainage. We talked a little bit about maceration when we were talking about sutures, but maceration involves softening of the skin due to prolonged wetness or soaking. Excoriation is the loss of superficial layers of the skin. Debridement is the removal of necrotic tissue from a wound. Shearing and friction occur when one layer of tissue slides over another. Both are mechanical injuries. Friction occurs when the skin slides against a surface. Shear is a force applied parallel to the skin in the opposite direction. Shearing is a result of gravity. Shearing occurs when one layer of tissue slides over another. For example, the head of the bed is elevated and the patient slowly slides towards the foot of the bed. The skin of the sacrum meets resistance of the bed surface while gravity pulls the patient down towards the foot of the bed. This means the skin and the bones are going opposite directions by pulling and stretching the tissue and distorting blood vessels in the area, causing destruction of both. So let's go over IVs and perfusion. Blood. Things to know about blood. It should never hang beyond 4 hours. So if I hang blood at 8 in the morning, it has to be infused by noon. It has to be. If I don't get it infused, I'm going to have to throw it away because if it hangs longer than 4 hours, it's going to be at a greater risk to grow bacteria. Blood needs to be hung within 30 minutes of leaving the blood bank. And again, this is to prevent bacterial growth. Bacterial growth occurs as it gets warmer. 18 gauge IV is best for blood administration. And this is to prevent lysis or breakdown of the red blood cells as they're being administered. If you cannot get an 18, you can use a 20, but an 18 gauge is best. We need a second line for any other types of medication. Like the blood is running by itself. I'm not going to put anything like IV drugs in any of the ports that the blood is going into. If I need to give any other type of medication or if I need to give anything IV, I need to start a second IV. I cannot use, while the blood is going in that IV, that's all it's dedicated for. We need 2 nurses to verify blood at bedside. You only use IV normal saline to infuse blood. Normal saline is the only thing that we can use to infuse blood. We need to use blood tubing. The blood tubing has a filter on it. That filter is good for 2 units of blood. Make sure that the filter is saturated with normal saline. So we want to make sure that filter is completely wet with our normal saline. And this is to prevent the cell lysis or the breakup of those red blood cells. I only have to wear gloves when I'm going to hang blood because I don't require any additional personal protective equipment because splashing is unlikely. There's your ABO compatibility chart. You need to know what blood types are compatible with what blood types. And you're just going to have to be able to identify, like if on your final, you'll have questions like, your patient is AB positive. Can they receive O negative blood? Yes, they can receive O negative blood. My O negative person, can they receive A positive blood? No. Allergic reaction, stop the infusion. Adverse reactions from blood transfusion usually occur within the first 15 minutes of the transfusion. Examples include of signs and symptoms that you might see include difficulty breathing and complaining of itchiness. An allergic reaction is the result from interaction with an allergen that is transfused in the blood with performed antibodies in the person receiving the blood transfusion. In some instances, infusion of antibodies from the donor may be involved. The reaction may present only with irritation of the skin and or mucous membranes, but also can involve serious symptoms such as difficulty breathing. Acute hemolytic reaction is the rapid destruction of red blood cells that occurs immediately after or within 24 hours of the transfusion when a patient is given incompatible blood. The recipient's body immediately begins to destroy the donated red blood cells, resulting in fever, pain, and sometimes severe complications such as kidney failure. Delayed hemolytic reaction occurs when the patient recipient develops antibodies to red blood cell antigens between 24 hours to 28 days after the transfusion. Symptoms are usually milder than an acute hemolytic transfusion reaction and even may be absent. Delayed hemolytic transfusion reaction is diagnosed with laboratory testing. So if at any time while I'm administering blood and I suspect that my client is having some type of blood reaction, my first priority is to stop that blood. Because if that blood is causing them harm, I don't want to put any more of that blood into the patient. And even in their lines, I'm not going to flush that line. I would probably even remove the extension set. So I don't even flush that little bit of blood that's in the extension set into that patient because I don't want to cause any more harm. We're going to notify the physician, depending on what the symptoms are. That's how, if they're having like mild symptoms, I might go on and take the blood to the blood bank, see what happened. But if they're having some really serious symptoms, I'm not going to leave the patient. But stop the infusion is the biggest thing, because we don't want to put any more of the blood that's causing them harm into that person. IVs, catheters can stay in place for 72 to 96 hours. When I'm going to insert an IV, I'm going to cleanse the site and I'm going to allow it to air dry. I allow it to air dry. I don't dry it with anything. I don't like dry it with a gauze. I don't fan it or blow on it to expedite drying, because then I'm just going to contaminate the site that I just cleaned. Dressing an IV site. Use an occlusive dressing. Use skin protectant like SurePrep in the elderly. The SurePrep will protect the skin and it'll still allow the occlusive dressing to adhere. If I use any lotions or something in an attempt to protect the skin from the occlusive dressing is not going to adhere. I want to use an occlusive dressing because I want to keep that site clean and I want to be able to visualize that site. If I chose to use like wrapping it with gauze to try to avoid adhesive on somebody's elderly skin, the gauze isn't going to protect the IV site from microbes, and I'm not going to be able to see it. And then when I'm hanging IV fluids, I want to write on tape. Like if I needed to label the bag, I'm not going to write directly on the bag with the Sharpie. I'm going to write it on a piece of tape and then put it on the IV bag. The rationale behind that is that some of the ink could possibly seep into the bag. Phlebitis is inflammation of the vein. I want to notify the physician. I'm going to remove the IV catheter from that site, apply a warm pack to the site. I'm not going to start a new IV in that same vein. I'm going to document the occurrence, the actions that were taken, like I put a warm compress on that, and client's response. Other things about phlebitis, it's inflammation of the vein. Something irritated that vein that caused it to become inflamed. It could have been the catheter rubbing inside of the vein. And when that occurs, that inflammation is going to present like with this red cork-like streak of that vein. That inflammation will be like hard, cork-like is the way you'll usually see it described. And it'll be warm and red. Infiltration, something happened that catheter became dislodged from the vein, and now it's like an interstitial area around the vein. If the fluid was still running, that site is going to be swollen because there's a bunch of fluid there, and cool because of all that fluid there. We want to remove that IV because it's not good, it's not in the vein, and we want to document, notify the physician, and we want to start the IV somewhere else. Bleeding IV site after IV removal. If I'm having difficulty controlling bleeding after I remove an IV, I'm going to raise the extremity above the level of the heart and apply pressure. Reasons why the AC or anacubital site is not a good choice for an IV. There's an increased risk for dislodgement of the catheter, increased risk for kinks in the catheter. It limits the patient's range of motion, and it eliminates the possibility of many veins distal for the arm and the hand. So when I'm starting an IV, I want to start low and then work my way up, because once I use a site, an IV, I cannot start another IV distal from that site. I can only move up or move proximal. You're going to need to be able to calculate IV flow rate. An example is 200 mils in 24 hours. That's going to be 83.33 mils an hour. So that's going to be 83 mils an hour. Central lines, the nurse will wipe the access port with antimicrobial swab for at least 30 seconds, flush the catheter before and after each dose of medication using the push-pause motion of the catheter. You're going to use at least 20 mils of normal saline after drawing blood to prevent clots or occlusion of the line. I'm going to use a 10 mil syringe to prevent catheter rupture. So I don't want to use like a really small, like a 5 or a 3 mil syringe because of the pressure it creates. So again, those smaller syringes can exert too much pressure, which can damage the catheter. I want to apply a skin securement device to the catheter to prevent dislodgement. Chest x-rays determine central line placement. The frequency of dressing changes is dependent on the dressing material. So our transparent dressings or our clear dressings, we are going to change those every 7 days. If it's a gauze dressing, it does not allow for visualization of the insertion site and needs to be changed every 48 hours. So our transparent dressings every 7 days, gauze dressings on central lines every 48 hours. So every 2 days, if I can't see it, it's a transparent dressing and I can see it, I'm going to change it every 7 days, or whatever your facility protocol is. And then if it becomes loose or soiled, I'm going to have to change it. So even if it's clear and it was changed 2 days ago and it becomes soiled or it's falling off, I'm going to need to change it. Implanted ports, it's like shaped like a disc and it's implanted under the skin during a surgery. Ports can be used for giving IV medications, fluids, like TPN, or taking blood samples. The most common place for a port is the upper chest below the collarbone. So when you're using these ports with a client, before you use it, of course, you're going to clean with alcohol. If you're using it before you use it to either draw blood or give a medication, if the medication is like like an infusion and it's going to take some time, you're going to clean it, you're going to put the needle in, and you're going to cover it with a transparent dressing, like if it's going to be like a continuous IV that you're using that port for. So when we think about these implanted ports, these are going to be good for clients who swim, like they can swim with these, they can shower with these. These are good for individuals who do participate in water sports. And just one more thing with the, I know we've already said this, but just to remind you, while this port is in use, like if I'm using it for an IV, I want to make sure that there's a transparent dressing over that needle and that insertion site while it's being used. Okay, so that concludes our review for the final. Please let me know if you have any questions.